Welcome to the GOTA virtual conference. Scan the QR code on the left to participate in our silent auction. The silent auction will run from October 1st to October 29th of 2020. Scan the QR code on the right to go to the GOTA online store. Thank you to our 2020 sponsors. Platinum level sponsor, the Shepherd Center. Gold level sponsors, All About Kids Therapy Services in the University of St. Augustine. And silver level sponsor, Hanger Clinic.
Shepherd Center specializes in medical treatment, research, and rehabilitation for people with spinal cord and brain injury.
We see 400 individuals with brain injury a year. We see over 350 individuals with spinal cord injury a year. Our staff have the expertise, we have the knowledge, and our outcomes exceed national averages.
All right, and we will begin with our first presentation tonight, which will be the admission process in occupational therapy.
Hi, good evening, everyone. Can you hear me?
Yes.
Perfect. Well, I just wanted to start off and say thank you so much for tuning in to our presentation. We are going to be discussing the admissions process in occupational therapy education, investigating academic and non-academic metrics in the application selection process. So we are from Augusta University, and my group members include Zana McNeil, myself, Mallory Babin, Erin Pyles, Breanna Trueblood, Bailee Cloutier, and Dr. Sharon Cosper. We hope that you enjoy our presentation, and I will get on to sharing my screen. 1 second. Okay, is it viewable? Perfect. All right, here we go. Enjoy.
Welcome, everyone, and thank you for coming to our presentation. We did our research on the admissions process in occupational therapy education, investigating academic and non-academic metrics in the applicant selection process. The researchers were Zana McNeil, Mallory Babin, Erin Pyles, Breanna Trueblood, Bailee Cloutier, and Dr. Sharon Cosper from the Department of Occupational Therapy in Augusta, Georgia. This is our poster, and the presentation will follow along with it. Establishing effective methods for the occupational therapy program's admission process is vital to ensure future growth and success in the profession. It is through these admission processes that the future leaders of the field are chosen, and it is important to verify that these selected applicants have the potential to transform into knowledgeable and effective therapists for their future patients. As stated in the literature, the overall goal for any allied health program's admissions process is to assess required criteria and identify the prospective students that have the highest potential for success, not only in the program's curriculum, but also in the field as a practicing clinician. Although the objective of finding the most suitable applicants is clear in this process, there's still a gap in the literature concerning what admissions components are most frequently utilized by occupational therapy programs, and which components of the admissions process allow programs to obtain the strongest occupational therapy students. The purpose of conducting this research is to identify the common academic and non-academic criteria utilized in occupational therapy admission processes and determine what methods are more effective at identifying applicants that will pass their NBCOT exam following completion of an occupational therapy program. Next slide.
So the methods section. This study conducted was a descriptive correlational study which aimed to describe the methods used in the admissions processes of top-ranked entry-level master's and doctorate occupational therapy programs. In addition, we examined the relationship between the admissions criteria component and the NBCOT pass rates among these occupational therapy programs. The independent variables for this study were the admissions criteria components, which were extracted from each program's website. The dependent variable for the study was the program's NBCOT pass rate for 2018 graduating class from each program. We utilized the 2020 edition of U.S. World News and World Report ranking for the category of best health schools, which provides rankings for various health institutions. Of the 198 OT schools, data was collected from the top-ranked 107 occupational therapy schools by extracting various admissions criteria data from their publicly available websites. Inclusion criteria for a program to be included in this study was that the OT school had to be one of the 107 top-ranked in the U.S. News and World Report and contain at least one of the following degree tracks: an entry-level occupational therapy doctorate, Masters of Science in Occupational Therapy, or Masters of Occupational Therapy. Programs were excluded if they were pipeline programs, post-professional programs, non-accredited programs, and programs that were ranked below 107 in the U.S. News and World Report of 2020. Next slide. Data utilized in this study was collected by one of 5 researchers. This data included topics including admissions and application process of each top-ranked program. Collected data included degree obtained, occupational therapy, centralized application service, OTCAS, utilization, bachelor's degree requirements prior to maturation, and other enforced requirements such as GRE assessment, minimum science recommendation, interview processes, observation hours, essay and writing sample, and prerequisite minimum final grades. NBCOT pass rates were recorded by each reviewer from the NBCOT's publicly available website for the year of 2018.
The information gathered from the public websites were inserted into a master spreadsheet accessible to all reviewers. Descriptive statistics were recorded regarding the frequency of the use of the specified admissions criteria components. Reviewers utilized a standard language to develop a clear system of codes when documenting the data, and all discrepancies were discussed as a group to increase inter-rater reliability. One of 5 reviewers recorded the presence or absence of each program's admission criteria. Each set of data was then reviewed by a second researcher to how the programs with NBCOT pass rates are less than 100% did COT pass rates.
Hi, everyone. Sorry about the technical difficulties. My classmate may be having some internet connection issues, so I'm just going to share my screen and continue on with the presentation, if that's okay with everyone. Give me one moment. Are you all able to see my screen?
Yes.
We are.
Welcome, everyone.
Of data is then reviewed by a second researcher to increase inter-rater reliability. Chi-square statistics for tests of independence were performed to analyze the distribution of admissions criteria frequencies for those programs with, with and without 100% NBCOT pass rates, and how that compares to what was expected in that distribution. The expected null hypothesis is that the programs with NBCOT pass rates that are less than 100% did not differ from the programs with NBCOT pass rates that were 100% in their use of the admissions criteria in question. A p-value of less than 0.05 was used to determine if the difference between the two groups were statistically significant. Next slide. So for our results, the following academic admissions criteria were identified to be used by more than half of the top 111 master's and doctorate level OT curriculums. 91.89% require a minimum undergraduate GPA, 90.99% require a bachelor's degree prior to matriculation, which is defined as enrollment in a university or college, and 55.86% require GRE scores. The only examined academic criteria that was used by less than half of the top 111 master's and doctorate level OT curriculums was the requirement of a math science GPA at 11.71%. Next slide. Regarding non-academic admission criteria, the following criteria were used by more than half of the top OT curriculums. 97.30% require letters of recommendation, 90.09% require personal statements, and 74.77% require observation hours. 61.26% require interviews. Of programs that utilize observation hours in their admission process, an average of 25.59 hours were required. Next slide.
Despite the lack of statistically significant findings between each admissions criteria relating to NBCOT passing rates, researchers found it interesting that the majority of top-ranked OT tracks utilize undergraduate GPA, while fewer than 12% of programs required a math science GPA in their admissions criteria. This is in contrast to previously conducted research, which demonstrates that nearly 70% of post-professional programs use math science GPA in their admissions process. This suggests that OT programs may be relaxing their emphasis on skills related to success in math science courses alone, and instead are focusing more on courses about developing skills that will produce a well-rounded student, in which a minimum undergraduate GPA may represent more accurately. Regarding non-academic metrics, more than half of the total programs included in this study require interviews as part of their admissions process. This is of contrast to past research, which demonstrates that less than half of occupational therapy programs consider the result of an interview to be an effective way to predict a student's success. While interviews may be beneficial in identifying characteristics of applicants that are difficult to assess through paper, such as professionalism, personability, and critical thinking skills, they're often time-consuming and require additional resources. As a result of this conflicting evidence, it's still unclear whether interviews are valuable to the OT admissions process. Supported by the results of this study, it can be inferred that OT admissions departments of the included programs are utilizing a holistic approach that blends academic and non-academic metrics. By utilizing this style of admissions, the goal is to produce successful OT practitioners following graduation that will further advance the field of OT and provide high-quality service to future clients. Overall, however, future research should be conducted to support these inferences. Next slide.
The limitations of the current study include the following. The definition of successful students, 2018 NBCOT pass rates, is not inclusive of transitioning programs or new OT programs. As more schools are beginning their doctoral programs, researchers will need to be creative in their methods to acquire outcome data that accurately depicts the success of students graduating from these programs. The current study was unable to include pipeline programs and transitioning programs in its analysis, thus impacting the ability to accurately assess the entirety of the top schools. Pipeline programs were not included in the study as their admission criteria greatly differed from that of traditional entry-level programs and would therefore skew the data towards outlier criteria in the admission process. Another limitation would be the frequency of change of the website's publicly available information from which the data was gathered. Reviewers found inconsistencies in the data gathered from examined websites as criteria was continuously updated for the following year's admission processes. Data was collected during the beginning of the coronavirus pandemic, which influenced the decision-making of some institutions, allowing exceptions to certain criteria. Next slide. Data analysis tests did not reveal statistically significant findings between each admission criteria relating to NBCOT passing rates. This suggests that although admission criteria may be indicative of student success within a program, it does not impact the student success as defined as passing the NBCOT exam. Other factors outside of admission criteria must then be associated with the program's overall NBCOT pass rate. Future research should be conducted to address other factors that could be more strongly associated with the program's overall NBCOT pass rate. Perhaps rather than focusing on the information available on a publicly available website, future research should examine qualitative evidence gathered from program faculty themselves, as this would better reflect the intentions and methods used by programs to produce successful students. This may include lived experience of students, fieldwork performance, or specific curriculum utilized within the OT program itself. Next slide. Here are our references. Thank you so much for listening to our presentation. We hope you enjoyed this content.
Thank you. We're going to be holding questions for the end, so we'll move on to the next presentation, a home-based mobile health-assisted piano therapy.
Hi everyone, can you all see my screen right now?
Yes.
Okay, perfect. Give me 1 second. I'm just going to minimize the window so I can see the whole presentation on my own screen. Hi everyone, my name is Chen. I'm an assistant professor at the OT department at Georgia State University. So I'm glad to see everybody here tonight. And I'm so sorry if I sound like a little bit distracted because my daughter is currently crying right now. Usually this is right now her bedtime. And then because I cannot put her in bed tonight, so she was crazy crying at this point. So sorry about that if I cannot really focus. So today I'd like to share my pilot data with you in a project that I collaborated with my colleagues in the OT department, that is Emily Buchman, I believe she's also here tonight, and also our chair, Kinsuk Maitra, and also I'm working with a professor at the Department of Music Education on this particular program. So based on the literature, so let me just move on here. So based on the literature, the music therapy is effective. We know that it's effective to help stroke survivors to improve their upper extremity function. Specifically in this project, we focus on something called active music therapy. That means that the participant have to take an active role to play the instrument during the training. So it is believed that because the pleasing melody or the feature of the music and the immediate feedback of the auditory feedback during playing the piano, it is believed that the music therapy can stimulate something we call auditory motor coupling to stimulate the brain, to stimulate the coupling and lead to the motor improvements. And in our study specifically, we're focusing on using a mobile health technology to provide the music training, to provide the piano training. So the idea is to use this kind of mobile health technology to increase people's rehab access and minimize the cost. To the best of our knowledge, this is actually the first time that the piano therapy is provided through this kind of technology. So the purpose of this study is to test the feasibility and then to understand the potential effects of this kind of home-based mobile health assisted piano therapy in patients with stroke. Basically, we want to understand whether if we provide some training at home and through an app, through a mobile health technology, whether that works for people or not, and then how people feel about using that kind of technology to get exercise at home. So in this pilot project, we recruited 8 participants who have mild to moderate stroke, and they have around, their age is around 58, and they have stroke onset around 2 to 3 years. This is our study design. So let me move up a little bit. So this is a 3-week training. So during the training, we will ask the participants to use a specific app. This is called Musician, and then you can see the picture down here. This particular app was originally designed for general public to learn how to play an instrument. For example, like a piano or a guitar. So it has like a series of exercise courses to show you how to play the piano. So we asked the participant to use the app and with the piano at least an hour per day. So again, this is a 3-week training. And then before the 3-week training, we visit the participant at home. So we show them how to use the app and then help them to set up the piano, everything. And then of course, we do some outcome measures and then screening tests. And then let them to do the 3-week training. And then after the 3-week, we came back to their house and then do the assessment again and do an exit interview to understand their feedback and then how they feel about using the whole program. And then we actually get the device back. So one thing I forgot to mention is we actually provide the piano and the whole iPad installed with the software, the whole set for them during the whole week, 3-week training. And for the specific outcome measure, we actually, let me move this to here. We measure the Fugl-Meyer score and the Nine-Hole Peg test. And here's the result that I want to show you. One thing that we are interested to know is like during this 3 weeks, do people actually use the device to do practice at home or not? And this is the individual data that you see from our 8 pilot participants. So most of, like generally speaking, there's no obvious decline during the 3 weeks. A lot of time during this kind of home training program is like, you will see that people use the training or do the training or use the device very frequently at the very beginning of the study. And then slowly there was like, trying not to use it or, don't really want to use it at the end of the study. So the good thing from our pilot data is that it didn't show that specific trend that the usage is decline. And then the average across all these 8 participants is around 33 minutes. But of course, you can see there's some big range, some variability over here. And generally speaking, we do see very positive feedback from our participants. This is our exit interview question. We ask them, generally speaking, how do you feel about that? Is it something you want to use? Is it something easy for you to use? Do you feel like this is helpful for you? And as you can see, most of the time, most of the participants did report that the piano and the app is very user-friendly, and then they feel like this is very helpful and relevant to their rehab training, and they do feel like they are their function improved. And then also one of the very important thing to us is they do report that they enjoy using the piano and the app to do the training. And then specifically, I include some of the comments down here. Some of the patients actually told us that they are actually very look forward to do the training every day and that they are motivated. And then some of them even mentioned that they finally don't need their wife to push them or force them to do the training at home every single day. They sort of like want to make it as their daily routine to do the training. And then also one of the participants also told us that they actually want to continue to do the training if we allow him to do it more than 3 weeks. So overall, I feel like this is really like the positive feedback. People do enjoy using the piano, enjoy using the app to do the training. We have, we do look at, and then we look at the clinical outcome measure. Again, we look at the Fugl-Myers score and the Nine-Hole Peg test. And then because we only have 8 participants, I ran the Wilcoxon Singren test. It shows significant, but of course we only have 8 participants. It's not very solid evidence at this point, but we do see that there's an improvement in the Fugl-Myers score, and people also finish the Nine-Hole Peg test faster. So this result indicate that they do show improvement in the motor capability and the finger dexterity. So overall, from the pilot data that we have right now at this point, we do feel like this is using the mobile health technology is feasible and acceptable way to provide this kind of home training for people with stroke, to help them to do exercise and help them to improve at home. One thing we do also notice that is there's some certain limitation, of course, for the app that we have. As I mentioned, the app itself was originally developed for general public. So there is some limitation. For example, the training always start from the right side. So it's not very helpful for people who have left side affected. So that we were thinking that's probably one of the reasons that you see some of the patient, some of the participants always show relatively low usage during the whole 3 weeks. So our next project is actually to continue collecting more participants, and we are planning to develop our own app so we can customize or we can tailor the program specifically for our patient with stroke. And then we are actually applying grants for that at this point. And one thing that I want to share a little bit further, we actually end up having more than 8 participants, and I didn't have the data over here, but we do find that there's an interesting correlation between the usage and the Nine-Hole Peg board test result. Meaning that the more the participants use the app to do the training, the more improvement that we saw actually from the Nine-Hole Peg tests. So we do right now have positive ideas and the general ideas for those for this particular way to deliver the piano therapy. So that's it for my presentation. Thank you for listening, and thank you for interesting in my poster.
Okay, occupational therapy, student outcomes from participation in interprofessional education activities, a systematic review. You are still muted, Jordan.
Oh, this actually is not my presentation, but I believe I can't hear the sound either.
Our systematic review was on the effects of interprofessional education on occupational therapy student practitioner outcomes. My name is Emma Adams, and my colleagues are Meg Carlton, Kaylee Todd, and Patricia Watford. The following presentation will cover this poster more in depth. By the end of our presentation, we hope that you will be able to understand and communicate the effects that various evidence-based interprofessional education interventions have on occupational therapy student outcomes, and discuss the gaps in the literature indicated by the systematic review as they relate to interprofessional education and its effects. Healthcare is a continually evolving and growing field. The U.S. Bureau of Labor Statistics projects that healthcare occupations will see a 14% increase in job growth from 2018 to the year 2028, adding 1.9 million jobs, making one of the largest occupations in the country. The World Health Organization defines interprofessional education as two or more professions learning about, from, and with each other to enable effective collaboration and improve health outcomes. Patients come into contact with multiple health professionals, no matter if it's just a routine doctor's visit or if they have a minor illness. So, effective communication and understanding among the healthcare team of a patient is critical not only in the quality of treatment, but the confidence the patient has in the provider. This shows the importance of interprofessional education and/or collaboration and how this plays a role within the healthcare field. Occupational therapists play a vital role in the healthcare team across various settings. However, interaction among healthcare professions does not occur daily during didactic training. The gap in the literature our group identified for our systematic review was that there is currently no published systematic review found that addresses outcomes related to OT participation in IPE. What this suggests is that a comprehensive search of this topic has not been conducted and should be added to current research. Systematic reviews are set in place to ensure that all practices are conducted on sound evidence. Since this specific topic lacks strong collated evidence, a systematic review would be the best addition to understand how OT students could potentially benefit from IPE. There is also a lack of evidence supporting the best way to implement IPE within a healthcare curriculum. However, there's evidence that supports the benefits surrounding this type of educational activity. The research question we asked is, what is the evidence supporting improved student outcomes as related to participation in interprofessional education activities in occupational therapy students?
For our systematic review, we began by using two of Augusta University's librarians to help us pick out the best databases to answer our research question, and narrowed it down to PubMed, CINAHL, and ERIC. After discussion, we created inclusion criteria to give us the best articles to answer our research question, including intervention IPE studies only in English, studies found within peer-reviewed journals, meaning that only articles reviewed by other experts in the field were included, articles only published from 2010 to 2020, at least 10% of the study's sample population must have included 10% of OT and or OTA students. The articles had to fall within the level of evidence of 1 through 4 according to FAOTA standards, meaning that we included all types of study designs ranging from systematic reviews to random control trials to case studies. And lastly, the study must have extracted specific OT outcomes to be considered for the study. To begin screening articles, we first started by reviewing the title and abstracts of all of the articles that each database found, given the key search terms used to narrow down results. The articles during this stage were only included or excluded if it was clearly evident the article was not relative to IPE and the research question at hand. Once we narrowed down the article results, each article was screened by reviewing the full text to determine if OTs were included and whether or not the studies were actual IPE interventions. Stage 3 included going through the narrowed studies to find which of the articles included OT-specific outcomes, rather than results based on the entire sample population. For instance, some articles included OTs among other professional students within their intervention, but failed to extract OT results specifically. Each of these screening stages were evaluated by 2 researchers of this study. and to evaluate the risk of bias within each study. The effectiveness study checklist was used and also evaluated by 2 researchers to ensure accuracy. This flow diagram represents each stage of the systematic review process that I mentioned on the previous slide. In the beginning stage, 1,368 articles were found through databases after removing duplicates. After screening those 1,368, 1,264 were excluded after the first stage. Once the full text of 104 articles were screened, 85 were excluded, leaving a final 19 to include within the results of the review. Please refer to your handout for a more detailed outline of the reason for full text article exclusions. As referenced in the previous slide, 19 articles met the inclusion criteria for the study. Surprisingly, all final 19 articles included in the review were level 3B evidence, meaning that each study used in the review conducted an IPE intervention on one group and conducted a test both before and after the intervention. As previously stated, the effectiveness study checklist was used to determine the strength of evidence for each article used within the review. All of the articles received a score of 21 through 30 out of a possible 48 points. To help us understand and analyze the different interprofessional education activities used within these studies, they were categorized into simulation interventions, such as the instructor acting as the patient, case study interventions, such as written or video case studies, and real patient interaction interventions.
We classified all included articles into one of 3 possible categories based on the intervention implemented as a means to compare outcomes observed between the different types of IPE interventions. The 3 categories included simulation interventions, true patient interaction experiences, and case study interventions. We defined simulation interventions using the same definition set forth by Coppola et al., which describes them as facilitating an environment which allows an individual to experience what a real-life situation would feel like in order to practice, learn, or gain a better understanding of a particular concept. To be considered a true patient interaction experience, our group decided there must have been direct contact and interaction between actual patients and the students within the respective study. Finally, we used the definitions set forth by Fagan, Oram, and Schoberg, which indicates that case studies provide an in-depth, multifaceted investigation into a single scenario that can be applied in an educational format as a means to analyze and apply theories learned in a typical classroom setting in a more quote-unquote real life and meaningful way. Of the 19 included studies, 9 were classified as simulation interventions, 5 were classified as true patient interaction experiences, and the remaining 5 were classified as case study interventions. Using AOTA's guidelines for systematic reviews, we determined the strength of evidence for each one of these 3 intervention categories. We found moderate evidence to support the use of simulation interventions and mixed evidence to support the use of both true patient interaction experiences and case study interventions. We determined many limitations impacting this systematic review. One being that all analyzed studies were level 3B evidence. Though this is the only evidence available which fit our inclusion requirements, this fact decreases the strength of our study. Also, many studies had to be excluded based on a requirement that OT outcomes be presented independent of outcomes related to other students. Furthermore, of the included studies, the outcome measures used vary significantly, hindering our ability to make accurate comparisons across the studies. We chose not to include gray literature, which is literature retrieved by hand searching the citations of other included articles. We felt the inclusion of this literature would make the sample size less manageable without providing great benefit, though it does mean there is potentially applicable literature that we may have missed. Finally, we only searched 3 databases during the completion of our systematic review, which also means there may have been some literature on other databases that we may have missed. Strengths of this study include those implicated by the nature of its being a systematic review. Included in this is the detailed search strategy described within the review, consisting of a full list of search terms, the ways they were combined, and the databases searched. These elements increase the replicability of this study. The multi-step screening process outlined in this review further supports its replicability and improves its strength. Finally, as the team completing the review consisted of 4 members, all articles screened were able to be reviewed and their inclusion or exclusion decided on by at least 2 individuals. Disagreements were presented to all 4 members and decided on unanimously. This level of attention to determine an article's inclusion status ensures that all articles were directly related to our research question and presented relevant information to the topic at hand. The impact our systematic review has on professional practice is focused on 2 main categories, one related to an AOTA identified research priority and the other having impact on OT education moving forward. Each year in their call for research, AOTA outlines a set of priority areas they want to see addressed through research. In the 2021 call for papers conducted by AOTA, one research priority outlined was the addressing of healthcare coordination, which this paper directly answers to. As our focus was on interprofessional education during students' didactic training and the effects it has on OT student outcomes, this systematic review is well suited to contribute to this area of research. Our research supported findings by Fox et al., which suggested that interprofessional education contributes to a more positive perception and understanding within the healthcare team. In terms of our research's impact on OT education, our research can be used to inform decisions related to the inclusion of IPE within OT school curriculums. As stated, though we found mixed evidence to support both case study and true patient interaction IPE experiences, we did find moderate evidence to support the effectiveness of simulation-based IPE experiences. This finding could easily be used to inform decisions related to curriculum development among OT programs moving forward, which inevitably will have a future impact on professional performance among occupational therapists and thus on professional practice. Thank you for taking the time to listen to our presentation. We appreciate your interest in our work. Please feel free to reach out if you have any questions for us.
What is task-oriented training? A scoping review.
Hi, my name is Veronica Rowe, Dr. Veronica Rowe. I'm an assistant professor at Georgia State University. It's my pleasure to introduce a scoping review, a presentation on task-oriented training that was conducted by students from Georgia State in my master's project class and as part of my research agenda. We'll start with Samantha Jakubczak. Thank you.
Hi, my name is Amanda Umpress, and like Dr. Rowe said, I am a current student at Georgia State University. I'll be beginning us off with just a couple of facts, initially noting that the American Stroke Association noted in 2015 that over 7 million people had had a stroke in this country. And then furthermore, Juckett et al. In 2019 outlined that it takes approximately 17 years for medical-based healthcare discoveries to work their way actually into practice. Keeping these two components in mind, the prevalence of the disability following stroke, along with this time it takes to implement active practice, we realize that an accurate and comprehensive translation of the literature truly must occur for us to be using the most productive methodologies and best healthcare for our patients that we treat. Timmerman et al. In 2010 and Wu et al. Found that the significant positive results through a rehabilitation intervention called task-oriented or task-specific training and the benefits that it had for the stroke population. When looking upon the methodologies of relevant literature, it's found that there are similar methods followed, but there has been no coherent definition or similar name for the specific type of training that's been followed throughout the literature. As more testing and significant results emerge, proving that this is a very effective and beneficial method for individuals who have suffered a stroke, a concise definition is imperative for knowledge translation and for the accurate implementation of this. This has led the researchers to question what is the definition of task-oriented training and how is it used in the literature. I will now pass it on to Erin.
Thank you for the introduction. So I will be discussing the methodology of this scoping review. First, the research team established our research question, which Amanda stated. We then established our search terms with the Georgia State University librarian and executed our search on CINAHL and PubMed. That search identified 664 relevant studies. All were downloaded into EndNote and charted alphabetically. We then divided those studies in half. The first half of the 332 articles were reviewed by 2 independent reviewers. Then the next half, the last 332 articles, were reviewed by 2 different independent reviewers, and that established the first stage of our 2-stage review. The reviewers applied inclusion and exclusion criteria during data review to narrow the scope. The inclusion criteria are adult stroke, interventions of task-oriented training, task-specific training, repetitive task practice, constraint-induced movement therapy, bilateral arm training, cognitive orientation to daily occupational performance, and any topic that is related to a repetitive task. Articles were also considered if they were published since 1990, and then articles that we could not get access to in English and translation was not provided, we were not reviewed. The included articles that were agreed upon between the review partners first, which completed the first stage of the 2-stage review. Then data was extracted from all included articles and charted. Examples of the data retrieved were the purpose of the articles, methods, outcome measures, interventions, and all relevant discussion of task-oriented training. These articles were reviewed by the entire team and approved for final inclusion for this study to complete the second stage of the 2-stage review. The reviewer consensus established the inter-rater reliability for articles to be included and excluded. The wide range of literature reviewed is in accordance with the methodology of a scoping review. The scoping review revealed themes within the literature, which were extracted from the articles and are represented visually based on the frequency of use. I will now pass it on to Sam Yakubishek, and she will discuss the results of our scoping review.
So we found some very interesting results from our study. Overall, our studies are published between 1994 and 2020. And we found originally 664 articles, but when we went through our inclusion and exclusion criteria, we narrowed it down to 172 articles. 29% of our articles use the term task-oriented training, 13% use task-specific training, 13% use repetitive task practice, and the remaining articles use something other than that. And you can see the actual terms they use within this pie chart here. Also, there's another graph to the right of it of the methods of reviewed articles. You could see here that the RCTs made up a majority of the methods that we found. And then you see at the top with our word cloud as the frequency of the words that were found within these articles that we included. So the larger the word that appears in the word cloud means that a higher frequency. And so if it's a smaller word, it's the lower frequency of the term used within the literature. So some of the most frequent words were repetitive, functional, task practice, task specific, task oriented. And you can see a further breakdown here. Some subcomponents that were identified within the literature of task-oriented training were described as repetitive task practice, mirror therapy, CIMT, and bilateral arm training. So that was consistent within the literature. Overall, there's this underlying conception for task-oriented approach. It's basically assuming interaction between the task, the person that's performing the task, as well as the context the task is performed within. There's a great quote from Askham et al. That I'd like to read to you. It involves resolving, reducing, or preventing impairments, developing effective task-specific strategies, and lastly, adapting functional goal-oriented strategies to changing task and environmental conditions. So at the very bottom here of our results is a definition that we came up with that we think is all-inclusive and sums up our results perfectly. So I'm going to read it to you now. Task-oriented training is an effective stroke rehabilitation intervention that focuses on the use of client-centered, repetitive practice of activities that are of high intensity and meaningful to the client. With a foundation in motor learning and control, there is an emphasis on mass practice of goal-oriented, functional, and challenging tasks that facilitates the client's active problem solving and leads to an outcome of functional improvement. So we're hoping this aids in knowledge translation and application into practice. So now on to Cassidy for a discussion of this data.
So our group conducted the scoping review because of the lack of definition of task-oriented training among all available research articles. This led us to the question, do researchers know what is involved in TOT methodology or how to use TOT to guide practice? There were principles of motor learning and control that were consistent throughout literature, but never a definition of what TOT is and how these principles affected implementation. The two-stage review found key components from task-oriented training protocols, methodology, and discussions from previous research studies, which created a foundation to build our comprehensive definition. The most important components when defining task-oriented training that were identified in the scoping review are functional, repetitive, meaningful, client-centered, and repetitive task practice. All of these components are fundamental to implementing TOT. Therefore, they are included in our definition. By creating a definition for this evidence-based rehabilitation intervention, it is impactful to not only research, but also to occupational therapists and physical therapists who are invested in providing the best care for their clients. The scoping review did have a few limitations. First, only studies written in English were reviewed, thus excluding studies written in different languages. By translating studies that were written in different languages, more interventions utilizing task-oriented training could have been reviewed. The study included 664 articles, limiting the generalizability. And lastly, not all studies found in our search could be used due to lack of free access to the full article. Next, I'm going to pass it back over to Amanda to talk about future directions.
Thank you. Yeah, so when looking towards the future, this current study did propose a comprehensive definition of task-oriented training based off our scoping review, and believe that that will help facilitate a knowledge translation from research to clinical practice. And our intent is that this comprehensive definition will increase the efficacy of stroke rehabilitation intervention and to aid both practitioners, clients, and research. We would now like to thank the Georgia State University faculty and staff who helped us throughout this process over the past however many months that we have been working through this, and then also Joel Glogowski, who is part of the Georgia State University library faculty, who helped us navigate the different databases and work to really have as much inclusion in our criteria as possible. Thank you all for being here and for sharing your time with us.
Thank you. Next, the impact of ultralight manual wheelchair on wheelchair skills and performance.
Hi, for some reason my video is not working. Sorry about that. So I'm Emily Buchman. I'm a clinical assistant professor in the Department of Occupational Therapy at Georgia State University. And Jordan Norris and Amber Wise are going to be the primary presenters for this poster. They are third-year DPT students at Georgia State, and they're finishing up their didactic courses before initiating their final clinical rotations next semester. We've been working on this interdisciplinary project with Drs. McLeod and Galen for over a year and a half now. So Jordan and Amber, if you'd like to start.
Hi, so I am Amber, and I'll start with the introduction. In the United States, it is estimated that at least 7 million adults are living with the consequences of a stroke. Sorry.
Hey, Amber, I think you're muted.
Can you hear me now?
Yes, you're good to go.
Okay. Yeah, sorry, I'm not sure what happened. So common consequences after a stroke include impaired mobility, with over 50% unable to walk after the acute phase, a sedentary lifestyle, difficulty with ADL performance, an increased risk for a recurrent stroke, and 40% using manual wheelchairs after hospitalization. Common challenges of a standard manual wheelchair include inefficient propulsion patterns, impaired performance of wheelchair skills, an increased level of fatigue and energy expenditure, and cardiovascular and musculoskeletal strain. While previous studies have altered wheelchair designs, only one study has investigated the use of an ultralight manual wheelchair for this population. A study on ultralight wheelchair use in persons with spinal cord injury concluded that an ultralight wheelchair provides improved wheelchair propulsion. So to continue, for our purpose, we found the challenge. Individuals with stroke often use suboptimal wheelchair propulsion patterns, yet limited research exists on the benefits of ultralight wheelchairs for this population. So the overall purpose of this study was to investigate how an ultralight wheelchair design affects wheelchair skills and performance in healthy individuals simulating hemiparesis. Our hypothesis was that measures of wheelchair performance, such as the wheelchair skills test and the wheelchair propulsion test, will be significantly different for ultralight wheelchairs compared to standard wheelchairs. Okay, and then as far as the methods go, we had 4 healthy subjects that were fitted for a standard commercial wheelchair and an ultralight wheelchair. After the fitting, they were given about 5 minutes to familiarize themselves with each wheelchair before the testing. Participants were asked to propel the wheelchairs using only their dominant arm and leg, simulating hemiparesis. Both the order of task and the order of wheelchairs used for each task were randomized. So we did a shortened version of the wheelchair skills test. It included forwards and backwards propulsion, maneuvering around objects, turning in place, coming to a halt quickly, and picking up objects. The other test we used was the wheelchair propulsion test. And in this, we took note of the number of propulsive cycles, the time, and the technique that the individual used over a distance of 10 meters. And so next, I'll hand it over to Jordan to go over the results.
All right, can you guys hear me?
Yes.
All right. I just wanted to note that on the left, we do have a picture of the skills test for picking up objects, and on the right we have what we set up for the turning in place forward and backwards. As far as our results go, in forward and backward propulsion during the wheelchair skills test and wheelchair propulsion test, individuals propelled faster and initiated fewer propulsive cycles in the standard wheelchair compared to the ultralight wheelchair. This had a 17.4% difference in propulsion speed. So here we'll go ahead and get into our graphs. The blue is the ultralight chair and the red is the standard chair. The error bars are for standard error. And in general, we did calculate percent difference because of our small sample size. These graphs for the wheelchair propulsion test show that the standard chair was found with greater speed, push frequency, and effectiveness. The highest percent difference was found in the speed category. In order to calculate percent difference, we did the standard chair value minus the ultralight chair value. Now we'll get further into the wheelchair skills test. Here you can see the wheelchair skills test with each skill listed at the bottom. Again, the ultralight chair is in blue and the standard chair is in red. Hold on one second, I'm trying to minimize so I can see this with you guys. All right. In the task requiring maneuvering the chair around obstacles and turning in place, improved performance was noted using the ultralight wheelchair with a 70.3% difference in offset of access from starting position during the wheelchair on spot and a 2.5% difference in time to maneuver forward around obstacles. Furthermore, when you go to break down each individual skill, the first 3 you notice are actually negative numbers. This means that the standard chair value was favorable. So that is for the rolling forward, rolling backward, and stopping in the forward direction. As far as turning goes, for clockwise and counterclockwise, these were positive numbers, and they were our biggest significance in terms of percent difference. These were actually in favor of the ultralight wheelchair. The final three skills that we looked at were the turning while moving forward, turning while moving backward, and picking up objects. These also had positive percent differences in favor of the ultralight chair value. In conclusion, this is a preliminary study, and it has demonstrated the feasibility of the testing protocol to be piloted among individuals with stroke. Our preliminary results suggest that the ultralight design may improve ability to maneuver turns and obstacles, which may be beneficial for individuals with a unilateral CBA by improving functional mobility at home and in the community. The next stage of the investigation will be wheelchair mobility of individuals with a unilateral stroke to evaluate the effect of an ultralight wheelchair on their functional mobility compared to their own wheelchair. This research aims to provide clinical practitioners and payer sources with data to support future wheelchair recommendations for individuals with stroke to maximize their functional mobility. And here down low are our references. I want to thank you all so very much for listening today, and please let us know if you have any more questions at the end.
Thank you. Up next is In the Eye of the Storm, the opportunity for occupational therapy and pediatric disaster recovery.
Hello, everyone. I'm Diamond Rashad, and I'll be sharing tonight. I'm an occupational therapist in Savannah, Georgia, so I'm just going to go ahead and share my screen. Okay, so a little bit of background about my capstone project. So I completed this presentation as far as my capstone project for Rocky Mountain University of Health Professions. And so I came up with this topic due to my volunteer experience about 2 years ago during Hurricane Harvey, dealing with disaster recovery and being able to work with different families and such, dealing with their kids and learning from them and their experiences. And so from this presentation, I hope that you guys are able to learn more about the impact of natural disasters and how that can impact families and also their children, and also how it differs from adults and what interventions are out there, as well as how OTs can be more involved in disaster recovery. So many children and families experience disaster recovery, especially as with climate change and different things going on, as we see this year with the pandemic. It can also be very unexpected to where it impacts parents and leads to more stress, and also in turn impacts the children. And so with children in preschool or even school-age children, they can have attachment issues from this with their parents, or exhibit regressions in their self-care and in their play skills. And this can be from a variety of things depending on the impact of the disaster. If they had to relocate, were they separated from their family or even other immediate family members, separated from their home for an extended period of time, how much did they see of the disaster? That can have an impact as well. And then adolescents, they can also experience social isolation, depression, aggressive behaviors, and that can lead to dysfunction with their school, work, and things that were typically enjoyable for them. And so with adolescents, you can also think about the different roles and routines that they had before. Did they lose their job? Did something happen to their school? Again, did they have to relocate and find new friends? So going through that grieving process of dealing with making new friends, and do my new friends like me, and how do I like my new school? So those things, looking at that impact on their mental health. And so since, depending on the impact of the disaster, it can add that trauma and stress to the well-being, OTs are equipped to deal with those traumatic experiences and the occupational disruption, as we are prepared to promote engagement with occupations, with their habits, routines, rituals, and those preferred occupations to foster that mental health and help them regain that sense of normalcy. So my first table looks at, again, those kind of regressions in self-care. So with bathing, grooming, toileting, and sleep, fear of water, or with grooming as well, fear of water, or also not wanting to engage in grooming, not really caring about it, having regression in toilet training, or not being able to sleep, parents not being able to sleep, and thus that carrying over to the younger kids as well. And then seeing that impact in those other activities such as work and school, having trouble completing homework, having anxiety about completing tasks, and not really being interested in doing anything at all. Not being involved in the community, and not being involved with other family members or with peers as well. And one thing to note as well is that in the literature also talked about the regression. So some kids also experience these things due to other traumas. It can be chronic traumas, or it can be a different acute trauma. And other kids also experience this from just sensory processing issues or anxiety from other related factors. But this one is also looking at that regression. Where were they before and where are they now, and what was in between, which would be that natural disaster, parents would say. And so from my search, what I was looking for was what OTs were already involved in this. And OTs have been involved in post-disaster regions for sure, especially internationally. What was lacking was the focus on pediatrics and focus on the children. That seemed to be more the articles that were on those that were in music therapy, art therapy, those in psychology, or psychology paired with occupational therapy. But from those articles, I did find that children want to be a part of the recovery process. They are essential to the community, and either they want to help others grow and learn, or they want to be able to say, this is how I want to be an active member of my recovery process, such as the use of group projects, art projects, being able to do like a mosaic, a documentary, being able to bind a book that talks about their experiences from their perspective. Another one that was completed in the Philippines, occupational therapists, they created an occupation-based play area so that all the kids in the community could come play, and then the adults could return to work. And as we see from right now with the pandemic, that's something that's going back and forth as well, is being able to go back to those everyday routines where the kids are somewhere and I can go back to my sense of normalcy as well, my occupations that I want to do. And then also online behavioral therapy, activity and psychosocial interventions and mental health interventions as well have had positive outcomes for adolescents and children with disaster exposure. And these go into more of the psychosocial interventions. So, and these came from a variety of other OT focused articles that talked about toxic stress. It talked about trauma-informed care, and also just mental health interventions for children and adolescents. So working on coping and resiliency, that would be stress management and play groups, doing performing arts, that could be a part of the community as well. Doing yoga one-on-one or as a group, mindfulness strategies, physical play, sensory-based approaches, and also social participation. That would also go into those anti-bullying programs, thinking about those adolescents and even kids going to a new school and maybe being in a whole nother state and not being able to necessarily fit in. Also community and school collaboration. So making sure that the school in your area or the school that you work at or that other OTs work at have trauma-informed care and trauma-informed interventions in preparation, as that's a big key to recovery, is that preparation beforehand. So they have some other interventions such as cognitive behavioral intervention for trauma in schools, bounce back, and trauma-focused cognitive behavioral therapy. So those are a couple of them. Bounce Back also does have an online program that has a training on there if you're interested in learning more about that. And then also mental health education, recreation and leisure. So this can be like sports. This can be going into that performing arts again, like the drama, song and dance, and then environment modification, going into those self-care tasks as well. And so future implications, this capstone project informs OTs of the opportunity the profession must do to build a greater body of evidence-based research and invest more in occupational-based interventions that benefit children with disaster-related trauma. And inspired therapists can pursue additional training or experience the American Red Cross, the World Federation of Occupational Therapists. They both have disaster-related trainings, and also seeking training in trauma-informed care, and getting experience as far as volunteering with the American Red Cross or other nonprofit or faith-based organizations in Georgia or in other states. And that's just to feel more equipped of dealing with the vulnerable population and meeting these families where they are, as they do deal with a lot of people who try to take advantage of them during natural disasters. And also this article or this capstone also looks to continue to explore these roles in pediatric disaster recovery and prevention, and also call those who are interested or are already working in these areas to have more qualitative and quantitative scholarship to help with this setting so that we can be able to pass on the knowledge. And that is all.
Thank you. Up next, we have Community Partnerships examining the benefits of faculty-led psychosocial level 1 program.
Can everybody see that?
Yes.
Can you make it larger or no?
Yes, I can. Yeah.
Perfect.
Is that better? Okay.
Yep. Hi, everyone. My name is Thais Petroselli. I am a professor from the University of St. Augustine, along with my colleagues. And today we're going to be presenting our poster on community partnerships, examining the benefits of a faculty-led psychosocial level 1 program. And with me this evening are Dr. Kisa Boykin, Dr. Sunny Faraj Bakht, Professor Inti Marazita, and myself, Dr. Thais Petroselli. Welcome. And today we're going to talk a little bit about a program we have been running at the university. In 2007, the AOT Fieldwork Ad Hoc Committee, so the committee that really looks at fieldwork within the context of OT education, had identified faculty-led fieldwork as an approach for us to take when considering meeting our educational needs in the 21st century. And as some of you may or may not know, in the newest ACOT standards, it lists faculty-led fieldwork as a way to meet the level 1 requirement. Our university had established a wonderful partnership with several psychosocial settings in our community, and our programs have evolved over time to really include faculty-led programming occurring at these sites. So for our level 1 experiences, we as the faculty go out to the sites and we're the ones running the programming, kind of bringing the students in with the clients, and we're modeling and then allowing the students to also experience it as well. So essentially, we are not only working with them in the classroom, we're also their supervisor when we go out to level 1 fieldwork. There are 2 major agencies that we have been partnering with. The first one is called Student Marchman Act, or SMA, and it's a big comprehensive behavioral healthcare provider here in Northeast Florida. Our level 1s are at 2 locations, a place called Residential Adolescent Programming, which is for adolescents who are in recovery from substance use, and a women assisting recovering mothers. It's called WARM, and that is another residential program that addresses mothers who are the youngest age, who may be in recovery, but also have children or are pregnant or expecting. This program's been great because they're also able to take us for our faculty-led level 1s on weekdays and weekends.
Our other agency is the Arc of the St. John's, and they provide a big comprehensive services for those with intellectual and developmental disabilities here in St. Johns County, Florida. Our level 1 students and our faculty are placed within the adult day training program there. We've also had wonderful success there. And both programs have been very welcoming and very encouraging of having OT in their setting. And they love that the faculty is coming with the students. Next, my colleague Sunny is going to talk a little bit more in depth about that.
Thank you, Thais. So, like Thais said, the 2018 standards speak to how faculty-driven fieldwork level 1 placements can be an alternative to our traditional fieldwork placements for level 1. The ACOT standards goals are for us to introduce students to the fieldwork experience, give them that first flavor, to apply knowledge to the practice, and to develop an understanding of the needs of clients. And mental health community settings, such as the ones that we have developed relationships with and have worked with our students to go, are really a great place to deliver this model of practice. Most community-based mental health programs don't have devoted OTs or OTAs working to provide services to these facilities. The partnership is a fantastic way to benefit not just our university and our students, but the communities within the organization and the students, and definitely most importantly, the clients that these organizations serve. This was a quick handoff, but I'm gonna hand off to, I believe it's, is it Inti? Are you next, or is it Kisa?
I believe it's Kisa.
All right, Kisa. Is she muted?
Yes, sorry about that. I was. So moving along and talking about the benefits of the program were, it was actually beneficial for the students as well as the consumers. The students learned to feel comfortable while interacting with the clients. They gained confidence in their abilities to plan and structure activities and environments, working in different environments. And the students became more apt at administering, and selecting relevant evaluation instruments, which turned out to be extremely helpful. The presence of faculty members, as Dr. Petroselli mentioned, as fieldwork educators, allowed for the connection between the didactic work to the fieldwork experience. Faculty modeling was critical to the students' growth and confidence in interacting with clients and in implementing group activities. The community partners were pleased with the outcomes of the partnership, which has led to development of community-based level 2 fieldwork sites, in addition to the continuation of our level 1 rotation. Now, I'll turn it over to Professor Marizita, who will discuss the link between psychosocial education and the fieldwork.
Thank you, Dr. Boykin. So the connection to the psychosocial course is closely tied into the course learning objectives. These experiences provide our students the opportunity to practice interview skills, therapeutic use of self, their clinical observation skills. They also have the opportunity to apply the OT process by assessing the clients and creating meaningful plans of care. The students also have the opportunity to develop group protocols and lead groups. And while leading groups, the students have the opportunity to manage group dynamics, as well as grade and adapt activities based on the client's performance during group intervention. Lastly, and one of the things that we get so excited about as faculty is the opportunity allows the students to advocate for the profession by educating other professionals about OT and our role in mental health. So what are some future considerations? So right now, one of the things that we struggle with are the gaps between cohort, from fieldwork experience to other fieldwork experiences with our students. And so in order to provide a consistency and a smooth transition, not just for the students, but also for the sites, some of the ideas that we're talking about right now is perhaps having our students volunteer when they're not doing their level 1 fieldwork experiences, also having having greater faculty presence, but also encouraging our OTD students who are interested in mental health to perhaps do their capstone projects at these sites. And finally, also thinking about developing some formal OT programming that we have a presence in these sites. So that way the transition from one cohort to the next, and also that transition for our clients in the community are more consistent. So at this time, we would like to acknowledge Stuart Marchman and the Arc of St. John for opening the doors for our students and making these experiences meaningful to them. And also we would like to thank everyone for attending and letting us share our work with you this evening. Thank you.
Thank you. And finally, we have the implementation of evidence-based practice and stroke recovery, rehabilitation.
Thank you. This is Dr. Rowe again, and I'm happy to introduce students from Georgia State University who completed this study, a survey on the implementation of evidence-based practice in stroke rehabilitation as part of their master's project coursework and a continuation of our research agenda at Georgia State. I apologize to the previous group for introducing the wrong first speaker. Virginia Settles, I believe, is our first speaker. Is that correct?
Yes, ma'am.
Okay, thank you.
Good evening, everyone. My name is Virginia Settles, and I'm an OT student at Georgia State University. Stroke is the leading cause of disabilities in the United States, impacting 795,000 Americans annually. This is a rate of one individual every 40 seconds who experiences a stroke. Rehab therapists, including occupational therapists and physical therapists, use a variety of interventions to help patients with strokes restore maximal occupational participation and performance. OTs and PTs commonly administer CIMT, strength training, biofeedback, and electrical stimulation for stroke rehabilitation. Task-oriented training has also emerged as a promising intervention for stroke recovery. However, there is conflicting evidence on the outcome effectiveness of these different interventions. Specifically for stroke rehabilitation, it takes approximately 17 years for healthcare providers to implement scientific discoveries, and only 14% of these discoveries are actually included in clinical practice. So as a result, there's inconsistency on how exactly rehab therapists can carry out these evidence-based practices into clinical practice. Throughout our research, we wanted to know how occupational and physical therapists can further improve functional performance outcomes and as a result, facilitate knowledge translation amongst each other. We conducted a needs analysis of current evidence-based practice by surveying occupational and physical therapists within the state of Georgia working in stroke rehabilitation. We looked at the degree to which participants rated their application of evidence-based practices, as well as knowledge and use of stroke rehabilitation practices with an emphasis on task-oriented training to identify current trends and interventions. Data from this survey provides preliminary insight into if a knowledge translation lag occurs in stroke rehabilitation, and if there are facilitators and barriers that influence clinical practice implementation. Now, I will let Callie tell you about our methodology.
Hi, my name is Callie Pospischal, and I'm going to be talking a little bit more about the methodology and then part of the data analysis and results section. So our study was a quantitative descriptive study that analyzed results from a 4-part online survey regarding stroke rehabilitation interventions based on the foundation of the person, environment, occupation model of practice, or also known as the PEO model. So this survey aimed to identify the current stroke rehabilitation interventions used and to determine the facilitators and barriers that influence their implementation into clinical practice. Participants were recruited via snowball sampling from existing contacts from professionals within the Atlanta area. Participants were then asked whether they had knowledge of stroke rehab intervention, and if so, were then asked to rate their degree of knowledge on a 5-point Likert scale. The data was collected through a research tool called Qualtrics, and statistical analysis was conducted through SPSS, which consisted of ANOVA, chi-square, Mann-Whitney analysis, and Spearman's Road test. Now, if I can direct your attention to the data analysis and results portion of our poster. So we looked at stroke rehab interventions using task-oriented training as an intervention, and then looked specifically into task-oriented training and its components. So looking at the top left-hand graph, profession versus use of stroke interventions, we wanted to focus on the difference between occupational therapists and physical therapists and their degree of use of stroke rehab interventions. Using the 5 most well-known and the 5 least well-known stroke rehab interventions, we compared their degree of use between OTs and PTs. Using the number of therapists that said they had knowledge of these interventions, we could compare their degree of use between professions for therapists who reported using the intervention either usually or sometimes, which indicates that they use the intervention in practice more than 50% of the time. The 5 most well-known interventions that we found through our data collection was task-oriented training, strength training, proprioceptive neuromuscular facilitation, passive range of motion, and taping, such as kinesiotape and leukotape. We found that there was no statistical significant difference between OTs and PTs and the degree of knowledge of these interventions. But through the Mann-Whitney analysis, we found that a statistically significant difference that OTs reported using passive range of motion and robotics more than as stroke rehab interventions more so than PTs. PTs, however, use strength training more so than OTs. Now looking at the bottom left-hand graph, profession versus use of task-oriented training interventions, we focused specifically on task-oriented training and wanted to know the degree to which participants use task-oriented training in stroke rehabilitation. Using the same measurements to Mann-Whitney analysis, we found that there was no statistically significant difference between occupational therapists and physical therapists in the use of these task-oriented training interventions. So now I'm going to pass it on to my peer, Andrea, to discuss the data analysis and results further. Thank you.
Good evening. My name is Andrea Merrill-Smith, OT student at Georgia State University. For the chart at the top right, we wanted to compare how knowledge of an intervention compared to the use of the intervention. We used 5 stroke interventions and took a percentage of the degree of use answers, a combination of sometimes and usually, in comparison to the degree of knowledge question. For task-oriented training and strength training, the degree of actual use is strong in the higher 90s. On the other hand, for taping, kinesio and leukotaping, that was only in the 40s, and PNF in the low 70s degree of use, which was quite a bit lower than the degree of knowledge. This shows that knowledge of an intervention doesn't always mean that it's being used. The chart at the bottom right represents where our service responses came from. We had the highest response rates from acute hospitals, that's the blue shaded area, from inpatient rehab in gray, and outpatient rehab in yellow. We also looked at the relationship between practice setting and the specific interventions. Chi-square found a relationship between practice settings and knowledge and use of specific stroke interventions. Therapists in urban and suburban settings reported having more knowledge and use of video gaming and virtual reality training than therapists in rural settings. Chi-square also found the relationship between practice setting and the use of specific task-oriented training interventions. Therapists working in urban and suburban settings reported using task-oriented training interventions, such as use of repetitive practice, functional task, use it and improve it, skill acquisition, and the use of intensity of practice. More often, they use them more than their peers in the rural settings. Next, we will go on to Sarah Kate.
Hi, I'm Sarah Kate Markinich, and I'll be explaining the implications of our study. So from our data, we found that both profession and years of experience do not have a significant effect on either the degree of knowledge or degree of use of task-oriented training interventions. However, the location of work setting, as in whether therapists work in a more urban or more rural setting, may have an important role in whether therapists know of stroke rehab interventions and the degree to which they use them as well. We also found that between OTs and PTs, motor control and motor learning interventions were the most well-known approaches, whereas interventions regarding technology were some of the least well-known approaches. But further research is needed here to determine if location of setting plays a role. Our scores could have been influenced by snowball sampling and also the inability to calculate response rate because of said snowball sampling, and also the lack of forced response in the survey as well. In regard to future directions, our results can help determine the difference between knowledge of and use of stroke rehab interventions. And finding this difference can help support the knowledge translation process by determining where the gaps in knowledge translation actually are. Again, further research is needed to determine other factors that influence the use of evidence-based practice in clinical settings. So finally, we want to especially thank the GSU faculty and librarians, as well as the OTs, PTs, COTAs, and PTAs who contributed to this research as well. Thank you.
Hello, everyone. Welcome to Video Modeling, School-Based Intervention for Students with Autism. My name is Shana Finks, and my presentation is Video Modeling, Self-Care Skills Intervention for Students with Autism. I am currently a faculty member at Georgia State University. I am the academic fieldwork coordinator as well as a clinical assistant professor. I have over 25 years as a licensed practitioner, and I have practiced in the states of Arkansas and Georgia, primarily in pediatrics. I have been at Georgia State for 1 year. This project was completed and in fulfillment of requirements for the post-professional doctorate that I earned at Chatham University in Pittsburgh. The setting for this project was the Gwinnett County Public School District in Duluth, Georgia. There were 5 autism spectrum disorder elementary classrooms at that time. 31 students with autism spectrum disorder were in these classrooms, and the collaborative school-based service model was used to provide services to support IEP objectives. When working with students with severe autism, teachers and OTs usually see barriers to self-care independence, often caused by decreased motivation, attention, and compliance, as well as significantly impaired communication skills, cognitive skills, sensory processing, and fine motor skills, which combined create a great deal of difficulty with completing steps to perform self-care skills. As OTs, we definitely don't want to only focus on the deficits or the areas of need. We want to also consider the strengths of our clients. And so students within the autism spectrum usually respond very well to visually presented information, respond well to repetition, and respond well to immediate praise and positive feedback. There were 6 students who participated in this project, ages 5 through 9, and they were all identified to be within the autism spectrum through physician diagnosis or through psychoeducational testing. There were self-help skills that were identified by their classroom teachers that their teachers had been addressing in the classroom during the school year without success. And each student was identified with an alias or a pseudonym to protect their privacy. The problem, intervention, and outcome question was, how effective is video modeling for increasing self-care skills independence for students with autism? Video modeling is proven to be evidence-based practice. It has been shown to be effective with teaching daily living skills. And this has also been shown to occur in fewer sessions and at a faster rate with video modeling compared to just using a live person to provide the model. Video modeling is successful with students with autism due to its visual presentation of instruction. And when combining this instruction with prompts, it is effective for teaching daily living skills. When using this intervention, we can apply Bandura's social learning theory in that behavior is learned from the environment through the process of observational learning. A video model provides a means of increasing imitation through observation. By including the student in the video, it increases the ability for the student to relate to the task being performed. And also by filming the video from the child's point of view as if they were performing the task increases relatability. The video method chosen was the point of view technique, and this was chosen to increase relatability to the task. Minimum steps were used to adapt for limited attention skills, and 2-word prompts were used to meet cognitive and receptive language needs. Reinforcement of applause was used at the end to provide positive feedback. The different self-care tasks that were addressed were completing a routine of hanging a backpack up in a cubby upon arrival to class, washing hands, checking the schedule to transition to the next activity, and completing a modified shoelace tying method. The intervention phase included preliminary data, which was taken week 1, and then post-intervention data that was taken week 6. During weeks 2 through 5, the intervention was implemented, where a point of view video was provided between 1 and 3 sessions per week by the teachers and paraprofessionals, and 1 session per week was provided by the occupational therapist. And as you can see here, each student received between 10 and 11 sessions. And while we took the data, we did also note whether or not the video was shown before the student performed the task and the data was taken. So as you can see here, each student increased over their performance over baseline of their self-care task performance. And in particular, Dan and Caleb began well over 50%, but they were still able to continue to perform to up to 100% by the end of 4 weeks. And Eli showed a great deal of gain as well, even though he started at baseline at 0, and then he was able to complete up to 37.5% of his task at the end of 4 weeks of the intervention. The COPM change scores revealed that overall each student increased from baseline either in performance, in both areas of performance and satisfaction. And there was only one student, Jared, in terms of washing hands, who had a slight decrease in the teacher's overall satisfaction of the performance of that task. But performance still increased after using the video for 4 weeks. And here is the qualitative data where each teacher at pre-intervention noted how effective, necessary, interested they were in video modeling, or how comfortable they were with video modeling. And then you can see at the end of the 4-week intervention, their perceptions increased in terms of the effectiveness and whether or not it was necessary as an intervention, and also how interested they were in using it in the classroom and how comfortable they were with using it in the classroom. So I'm glad to see those measures increased after the 4-week intervention. So overall, we see that each student's performance increased from baseline in the number of steps completed, and also when the teachers rated their performance using the COPM. And then each teacher's perception of video modeling increased from before the intervention to after the intervention. So this project correlated to the literature in that similar participants were utilized in the project. There was video modeling using the point of view method, and the use of applause for motivation at the end of each video model was used as well. So the significance of video modeling to occupational therapy is that it is evidence-based, it works well within a collaborative model, it shows the innovative use of technology, and it is the practical use of readily available technology sources that we see in classrooms every day, such as smartphones and iPads and iPhones and desktop and laptop computers. Implications for practice are that video modeling is very effective when OTs and teachers collaborate together. Skills are acquired over a very short period of time. It is cost effective in that you're using the technology that is readily available to you. For references, please refer to the handout for this poster presentation. And thank you very much for viewing this presentation.
At this point, we'll open it up for questions. So feel free to unmute yourselves, turn on your video, and we can start some interactions that way.
Hi, can I ask a question to the group that just presented?
Yeah, go ahead.
I was just curious, where did you pull your therapist from in terms of like here in Georgia or all around the US?
Yeah, so participants were limited to within Georgia, and actually most were in the Metro Atlanta area. And we also, I don't know if we said this or not, I think we did, but it was the therapists that we did survey from, anyone that was not working in stroke rehab before the previous 5 years, so within the last 5 years, were not included in the study as well, just to be able to get the most current healthcare practices.
Okay, thank you. And was it 80 total between the 4 different like PT, OT, OTA?
Yes, I think it ended up being majority OTs is I think 70-30 OTs.
Yes, 70-30%.
Yeah.
Of the 80.
Cool, thank you guys. It was a great presentation.
Thank you.
Thank you.
Yeah, this is Irma. I'm interested in what you all think of those findings. You know, the non-significance. What do y'all think about that?
I think that there's a lot to be further analyzed in terms of resources available in like locations, and then also practice settings, and then as well as what type of continuing education supports are available for the people that participated in our survey. We had descriptive data on it, but it was too inconsistent based off the way that people responded to to the free response about their continuing education to find trends within that. So I think that expanding the survey for a longer amount of time, or maybe doing the tri-state area before going fully nationally, and then further looking at like urban, suburban and rural areas with access to like resources, continuing education, things like that would tell a lot about finding significance between, you know, the more traditional motor control, motor learning therapies that are being used, and then more up and coming therapies such as like music therapy and robotics.
Yeah, and to add on to that, I think it's through our study, we found that this is definitely a foundation, that more research needs to be done regarding this, and more inclusive, to have more of a balance of PTs and OTs and OTAs and PTAs. And then I also wanted to highlight about the descriptive data as well. It was interesting to us, we found that a lot of barriers with continuing evidence-based research and looking into evidence-based is time. And so a lot of management and productivity, a lot of people made comments about that, which is interesting as well.
I think overall, it provides us some support in that we need to promote knowledge translation, that therapists, like it was said, know about things, but because of certain barriers like time and resources, are not always able to implement it. So we really, personally, I'd like to focus on that knowledge translation and helping overcome barriers and facilitating the implementation of evidence into practice.
Right, makes sense. Thank you.
I feel like that's an age-old problem. It permeates every setting.
Yes, yes, it does.
I have a question for the faculty-led psychosocial level 1 program. I apologize, I'm not familiar with what faculty-led looks like. Can you explain just, you know, how that differs from a traditional level 1 program, and just some of the details of what that would actually look like to everybody participating in that experience?
Yeah, I mean, my colleagues can jump in, but I think for me, I'm actually new to the university. I've only been here about 2 years, but I came from a more traditional program where our level 1 students, we kind of found a site, we signed them out, we sent their paperwork and their syllabi, and we had an outside supervisor for level 1. Whereas here, we're the ones teaching the course, it's our psychosocial course, but then instead of assigning them out to a traditional level 1 site, we go with them to the site. So we're the ones who are deciding what the interventions are, we're doing the treatment plans, we're kind of guiding the entire intervention there and supervising them on site. So we're also the ones who are doing their level 1 fieldwork evaluation as well. And then we're connecting that back into the classroom. So we're actually physically on site with them. So we go out with them to the site to run them. Well, now we're doing it on Zoom, but before COVID, we were going out to the sites with them and actually doing the program, modeling the program, and then having them participate in the programming. So it's different in the fact that there's no external level 1 supervisor. We are the level 1 supervisor. And it's also like our practice areas as well. Like we've all identified as psychosocial practitioners as well. So they're seeing us practice our practitioners, which is kind of cool, because sometimes that wall there, I think sometimes it's like seeing your teachers at the supermarket that you think they sleep at school. I think sometimes our students feel like you're really OTs. So it's kind of cool. I don't know if any of my colleagues want to jump in here.
Yeah, I want to dovetail on what you were saying, Thais. One of the neat things that I love about faculty-driven fieldwork is that we can really help make the connection between what is happening in lecture and lab, and really being able to bring that to life when we go out to those sites. So it's really easy for us to like step in and say, hey, remember we were talking about, you know, the blocker, that being a role in group dynamics, you know, that was a perfect example, right? So, and look how you managed that, and look how you were able to redirect that energy, right, within that group. So those are one of the things that I really love about faculty-driven fieldwork, is that you can really step in, intervene while it's happening, and also provide that feedback on the spot, right? I mean, obviously not when it's happening, but afterwards, we always have a debrief about what occurred in the session or how the fieldwork experience went.
I have a question, and you guys know that I love it too, because that's part of what I do. Have you guys thought about, and this is wild because I've done it and it's wild. Have you thought about alternate supervision models? Like, for example, I would get 4 level 2s a semester and 8 level 1s. And the level 2s would help supervise the level 1s because we didn't have quotas or techs. And so, and I would have the level 2s pre-edit the notes and the treatment plans from the level 1s for me, and it really sharpened their skills. But it's a bazillion things to juggle. But I just wanted to say that, you know, maybe that could be something.
I think we're, oh, go ahead, Sunny.
So I can kind of speak to some experience to something similar to that, Jennifer. We had an OTD student at the residential adolescent program where I supervised level 2s as well. And our first round of level 2 students happened. And I think it was a gift from COVID as well to rapidly unroll our level 2s with the site. The site needed interaction and they needed intervention with the students because they were so restricted. This is a vulnerable population. So it was a learning experience for our students as well. But I had an OTD student I was mentoring also at the same time, and she actually did just that. She helped them kind of guide them through their group intervention plan and also help pre-edit and set the expectations for their notes and documentation and the process involved. And it kind of translates. What's nice is now those students, so my OTD student finished, she's graduating tomorrow, which is exciting. And so those 2 students finished and they translated that same process with the overlap of the next set of level 2s. And so they set the same expectations for documentation, same expectations for group intervention. So it actually helped alleviate a lot of pressure, at least in the beginning as they transitioned, because they could mirror the activity. And I think that this was the benefits of COVID scheduling for us with fieldwork. We'll see what happens when there's space between them. So I don't know if any other,
As far as level 1, Jen, I know what you're saying because I used to do it when I was at a site as a traditional level 1 fieldwork supervisor. My level 2s always supervised my level 1s because it worked great. I think, you know, that's coming next. And I think that probably would have been the next logical step had COVID not stopped everything. So like Kisa had her level 1s at the site that I had level 2s. And we had started rotating them in and we were like, hey, next term, let's turn this up a peg because there's no reason that we can't make this work. So that is definitely going to occur. And I love an alternate, you know, supervision model myself.
The AOTA, oh, sorry, Kristen.
I was going to say, what does establishing that contract look like for those facilities when you're trying to explain this model? Or are these only settings that you personally have a relationship with? Like, what is bridging that? If other schools are hearing about this because they're struggling to find placements, you know, let's assume COVID isn't a factor. What does that process look like?
I think we've really targeted places that don't have OT on site. So for them, they're like, wait, you're going to send a free OT. And it's really kind of following that up, kind of not promising, but showing what OT can do for their facility. You know, and I'm speaking, people before me really, you know, Inti, Kisa really put a lot of legwork into this and a lot of rapport building. And, you know, it is part of your job as a level 1 faculty to continue that rapport building and stuff. But we've really targeted sites that don't have an OT. So they've actually really welcomed us because they're like, help. Like we all know not-for-profits operate on a shoestring budget. So they're like, you're going to come help us and do cool things with our clients. It's awesome. And I'm sure Indy can talk more about that.
Yeah, and I know Kisa, because Kisa and I, we met with the folks at Stuart Marchman, and I know also with the ARC of St. John's. You know, it really was about, we already had an established contract there was a level 1 before. And I think with students, really, one of the things that we found was that students didn't understand their role when they went out there because they didn't have an OT to look at or, you know, or see how OT really looked in these settings. And 2, the facilities didn't really understand what an OT was supposed to do there. So it was really difficult to supervise. But I can tell you that Kisa and I, we went out and we really did some education and some advocacy and explained to the folks. It was, you know, a couple interviews, wasn't it? A couple meetings where we met, sat down, and this is what we can offer. So there's a lot of that pre-work that happens. So if anybody's interested, it really is a matter of getting yourself out there, making those connections, making sure that there's a contract in place, either through the fieldwork department, or maybe that's something that with the fieldwork coordinator, you can work together. That's something that we did. We already had an established contract. So it was really easy to go in there and just set up meetings and really educate the folks at these facilities about OT and how we can mutually have impact, right? How we can really bring about some good advocacy and good, just good partnerships overall, you know, give back to the community.
I also have a question. Do any of you have any of the students that experience this setting currently in the participant list? And would you want to maybe volunteer them to give some feedback regarding this? Or
I don't see anybody.
What's
You know,
funny is
I don't want to sugarcoat it, but like, you know, it also has its detriments. There's a downside too. Like sometimes it's nice to have that external level one to validate like, hey, there's an issue or things are going better. Like it's nice to have that outside clinician. And also, you know, workload wise, it is a considerable amount of work to teach the class and then also do the level one as well.
And as far as the contracts, we didn't run into issues with the contracts that were already in place because these were underutilized, non-traditional sites. And so these sites, although they had sent students, level 2 students before, they weren't currently being utilized. So it wasn't a matter of us taking sites or contracts that were already in place. So it was a win-win.
Yeah, I think that's the beauty of it, Keisha, is that they're underutilized. So that's another plus. Good job.
Are you aware of any of these sites that since having the level 1 went on to figure out how to actually have a therapist on staff?
Not with COVID.
Not with COVID, but
I think we're headed that way though.
We're getting close.
So the residential program that we have level 2s at and had an OTD just submitted a grant with Cigna Health for up to $115,000, and they can give a lot, any amount up until that point, and it was just for the OT program. And so our level 2 fieldwork students that started within 2 weeks of that were a part of developing that grant, and we used MoHost. We used all of the OT interventions, OT evaluation tools to support the grant, and it looks very promising. So we're looking forward to expanding an actual OT program on site, and the next step is to find funding externally for a paid OT position. So fingers crossed.
All right, and my final question for this group, since I feel like I've been drilling you, is can you think of any other practice settings that you think this would also translate to besides the psychosocial aspect?
So I can speak to that because we've actually done this also with our pediatric course, where we have made a partnership with one of our local public schools systems. So St. John's Public School District, we actually go out to the schools and we take our students. So we rotate through a couple of different schools. So each one of the instructors within that course goes out with, you know, about 10 students, and they experience also pediatrics. So you can also do this with the pediatric course. And I believe even with our adult course, we're all in geriatric courses, we're doing the same.
Yes.
So we can translate this over to other intervention settings.
They work very closely with local skilled nursing facilities.
Yep.
Any additional questions for any of the groups?
I have a question. For the first group from Augusta, I think it was, I wanted to know why, like what was your cutoff, like reasoning behind, I think it was like 100 something schools for the OT schools. I'm just wondering why the cutoff. You might have mentioned it, but the video cut out.
Hi, thanks for inquiring about that. So the top OT school list went to about 250. So we wanted to make it an attainable amount so that we can kind of capture all the data that we wanted, because it was a lot of data collected. So we chose the top 100, but there were a lot of ties due to tied scores in their peer assessment score that the ranking used to put them in order. So that's why we went to 107, just how the overlap of ties had went to.
Thank you.
For the task-oriented training group, the scoping review, what do you think was the most surprising aspect of your review that you found?
I can start off.
No, you got it. You got it, Erin.
I would start off by saying I was surprised just by the lack of definition to begin with, just because we even talked about it in our courses, what the components of task-oriented training are. So I'm surprised there wasn't even a definition asserted by a textbook. So like just that basis not being there was one of the most shocking things for me.
I think one of the most shocking things I read was that one of the studies that had the most detailed methodology of it and had it laid out, I think in one of the better manners that we saw, didn't reference task-oriented training at all. They didn't really use that terminology, didn't do anything like that. They referred to it as training through repetitive tasks or things like that. And I just thought it was very interesting that there were articles that would name that as their specific method in which they implemented therapy and not have a clear definition of it, so that you really couldn't, reading that article, replicate that study at all. And it was just very interesting, I guess, kind of reiterating what Erin said, just the inconsistencies between it, I guess I would define that as.
And I apologize if I missed this during your presentation, but were there other terms that were frequently swapped out in the literature for it? And if you had to predict a term moving forward, do you believe it will be the term task-oriented training that's used, or the phrase I should say?
That is the term that we asserted should be used because it was found most often in the definition, in the descriptions, I'm sorry, of the method and the intervention used. And there was a word cloud that we presented as well. And essentially what we did is we went through the methodologies and the studies and put all of that information in their own descriptions into this word cloud generator. And that's what we found came up the most, which also felt good because that's what we had kind of discerned reading it on our own. So then when the physical numbers come and support you as well, that's nice.
The other terms frequently used that we noted and were included in our search were just repetitive task practice. Oftentimes that is what it was described as. They didn't necessarily assert the name repetitive task practice. They were describing the practice as being repetitive and a task practice. So we believe that task-oriented training is really what encompasses all of that. And so we want to assert like a uniform name as well as a definition, just so we can have that consistency in practice for care.
Yeah, I'm very interested in your own words, one of you guys. What tell me what task-oriented training is?
So based off of the research that we have done and what has been found to be most effective is task-oriented training, as we like to refer to it, or TOT for short, if that's easier, is something that is completely client-centered, because that motivation is such a huge factor. So yes, as the OT, you're going to find things that they need to work on, but finding something that's meaningful to the client, which I think is also just a part of the client-based care that OT works to provide, but something that has a high intensity that has shown that people can actually handle. Sometimes I know it's skeptical if someone's had a very significant stroke, you don't want to push them too far and cause fatigue, but something with high repetition, high intensity, meaningful to the client, and then is graded as you go. So you're constantly kind of wanting them to reach for more and really creating that just right challenge is something that I would personally describe task-oriented training to be.
That's wonderful. A good job. And the just right challenge brings me to, so it's applicability to pediatrics, adolescents.
Yeah, after doing this research, I really think this is something that could be a benefit to people across all rehabilitation settings. But of course, our research was solely in stroke. But yes, I also agree with you. That brings to mind pediatrics for sure.
I would like to add to that task-oriented training as an approach is not limited just to stroke. It can be much used in pediatrics, and all the subcomponents that have the elements of task-oriented training are already being implemented in pediatrics, just depending on diagnosis and such. So we very much see a future with this across multiple diagnoses.
Good job. School systems too. Good job. Good job, everybody.
I'd like to add, personally, I think another component that is frequently not cited and emphasized in task-oriented training is the idea of active problem solving, really promoting your client to help start solving their own problems and developing a sense of self-efficacy. I think that's inherent in it, but it's not always defined, and we don't capitalize on that maybe as much in the literature as we should. Just my own opinion.
Certainly. I am also curious to hear from the students regarding your level 1 and 2 placements. And I apologize for not knowing offhand where you all are in the process. When you were working in the clinic or with clinicians in the field, what do you feel like you were seeing or trends that you observed?
I'm sorry, is this to all students or is this to the scoping? I just want to make sure.
I think I was thinking initially just the presenters, but yeah, I mean, I suppose any of the students can chime in. If you want to break the ice, feel free.
Sure. So I would say that my first level 1 was in a hand clinic. And so I feel the nature of that because it is so specific. I believe that there was a lot of TOT implemented there, not specifically by name, but you could tell a lot of the components. And then my second one in the spring was actually at a hippotherapy location. So that was a little bit more structured in its own right. So maybe someone else wants to jump in on that one.
I can jump in. So my experience for my first level 1 was in acute care, and I saw a little bit of neuro, but it was a level 3 hospital for trauma. So they did, the patients definitely had different severity levels. So I didn't see as much TOT per se also, but after participating in this project, I definitely have more of a TOT lens and wanting to focus on stroke just from learning so much about it. I feel like there's just so much more that we can do with this program. So that's really how it's framed it for me. I'm just looking forward to doing more in this realm.
And then to all of the presenters for that topic, what do you think the long-term effect is if we're all using different terms in our documentation, and the long-term effects on our field are with that type of variation?
Erin, okay, I'll go. I just think based off of the research that we've done, this is a very effective method that can help people make significant gains in regaining their function. And like Dr. Rose said, promoting that self-efficacy. And I think I'll say our duty as clinicians is to provide the best care possible. I think that's the most ethical thing we can do. And so the idea that there is this incredibly effective and important and sorry, I just think that there's this opportunity for us to do a lot of good that a lot of patients have said was really impactful, meaningful, and productive for them. And I believe if we're not creating situations where people can replicate that and can study it more to improve upon it or find, its faults and fix that or implement something new, I just don't think we're doing the best service that we can to our patients. And I think when you sign up for this role, that's kind of the obligation you sign up for.
And sorry, I was going to address the billing and documentation. I believe that not having the consistent name, it takes away from the fact that it is an evidence-based practice. So when someone wants to go look it up for replication or to see why you are billing for this, it takes away from the work that we're doing. So having this definition really shows exactly the protocols used, the methods used, and how this specifically helps with the neuroplasticity and why this is an effective intervention to insurance and et cetera.
I agree. I wanted to reiterate that. I think using different terms, even if we're all doing the same thing, by using different terms, it lessens our credibility and our ability to replicate and to pass on the different things, especially in research. If we're doing similar things, but we're calling it a whole bunch of different names, it makes it extremely difficult to show the proof and the evidence behind what we do. So I think it's important to use the same semantics.
I completely agree. I have a personal story with that too, with the place where I work. I work at the Shepherd Center, and when I started off in brain injury, our disorders of consciousness program, a Shepherd-centric term because there are many, we called it PrEP programming, which stood for pre-rehab educational programming, and that was for people in the disorders of consciousness. And here, because Shepherd is, you know, kind of Disneyland, and after people get there, they don't leave. A lot of times we're all trained internally. We were publishing papers with that terminology opposed to using the term disorders of consciousness programming. And it had a huge it had long-term effects. And it wasn't until like my 4th or 5th year there that we finally changed the name of the programming, and then went back and published updated information with the proper terminology. Can have significant impact on, one setting in particular producing research, but the field as a whole. So I think that's, it's a great topic to cover. And I like the fact that you've covered it with a very timely aspect of occupational therapy. Thank you.
Absolutely.
Does anyone have any final questions since we're at the top of the hour? Okay. Well, before we leave tonight, I want to remind everyone that to receive your continuing education certificate, you'll need to go onto the conference website and complete the assessment for this, this presentation. So make sure to go back to the actual presentation, button for this session and complete all of the questions for that, which you'll find on the right-hand side of the screen. If you have difficulty navigating to that, there is a video on the YouTube channel that I'll actually take you through step by step. And then finally, I want to go ahead and Irma loves to take a group shot after every one of our presentations, and just also just for us all to actually give a round of applause to all of these great presentations. And I appreciate everybody, participating in such a format. I think I've really enjoyed this format, especially for the poster presentations, because I get to hear the interactions that I think normally I try to rapidly hit multiple posters and you don't get time to really absorb each one. So thank you to everybody.
Good night.
All right, and I will go ahead, if you guys will all smile big, I'll take a little screenshot.
Yeah.
Wonderful. And if you guys have any other materials that you want to share, or if you have information that you want me to edit in post-production, please feel free to contact me. I will put my email in the chat box here. It's just kristen.jean.weber@gmail.com, and I will upload any additional material, including Dr. Finks' presentation as well. So thank you all for coming, and have a wonderful night.
Okay, thank you.
Thank you. Bye.
Thank you.
Thank you.
Thank you.